So, good evening and welcome to this session on word rounds. I will share my screen and we will start off. Let me just. Okay. There you are. So, what I plan to do in this is basically discuss some simple, straightforward post-operative situations. Also, one or two slides on intraoperative issues and how you deal with it as a surgeon. As I said, the main purpose of this discussion is to give you the skill or the ability to work things out when there is a problem in the post-op situation. As the common adage goes, if some surgeon says that he has had no complications, either he is not operating or he is lying. Only one of the two. Essentially means all of us will have difficulties at times, and we should be up to speed in terms of dealing with these difficulties. And that, of course, comes with experience. It cannot happen on day one of your graduation. And it also, but from day one, you can always develop the skill of thinking about all the possibilities that can give you a given set of symptoms, and ruling out one by one, you come on to the real complication that has occurred, and then you deal with it. That is the decision-making process. So I'll start with very simple things. Preference to Indraja and Pawan because the exam going. Of course, we'll involve others also. Patient post-laparoscopic cholecystectomy, as you all know, the next morning they're sitting up, smiling. They will have probably had breakfast by the time you go as a consultant. Everything is stable, and you'll just say hello to them and probably send them on their way home. That's the usual. But you walk in, and the patient looks a bit unwell. Not just the sprightly, bright person that you would expect the next morning, and complains of breathlessness. You say, I'm feeling short of breath. All right, and says, I have to take deep breaths to be comfortable. Now, how do you proceed with clinical examination? What are the things that you look for? And what are the steps in terms of investigations that you would undertake? First of all, when somebody is unwell the next morning, just think of all the possible scenarios. Indraja.
Hello, sir.
Yeah.
So, first I would like to check the vitals, sir. Whether
no, just tell me what are the. We'll do that, but first tell me what are the. When somebody is unwell the next morning, what are the thought processes that you have? What are the problems that you would anticipate?
First thing is whether ongoing bleeding must be there, sir.
All right. And, so you classify that into two major issues. One operation related, second one not operation related but patient related. Okay?
Yes, sir.
Yeah, go on.
Yes, sir. Sir, operated related may be ongoing blood loss.
Okay.
And the thing is, like post cholecystectomy, there may be cystic duct stump blood, sir.
By leak.
By leak. Yes,
okay.
Sir.
Good.
And sometimes it may be thromboembolism also, sir, because patient is complaining of breathlessness.
Day one?
No, sir.
Unless
maybe
the patient was in bed
3.
for, not even day 2, it will be day 5. Unless the patient was bedridden for the previous week or 10 days before you took the patient up for lap chole. Okay. I wouldn't say it will never happen, but put it last on the list. When you think of these possibilities, you must put it in the order of possible frequency of occurrence. Yes. Agreed bleeding, agreed by leak. Okay. What else? Think of non-operation related causes.
Maybe atelectasis, sir.
Okay.
Atalics. Yes, sir.
Yeah. Just bronchospasm,
Yes, sir.
for whatever reason, aspiration, whatever. Maybe patient has COPD and left heart failure,
Yes.
LVF. Yeah, LVF. These are the common things that we think of. So now you say, to rule out all this, what are the things that you look for clinically and what investigations would you ask?
So first, clinically, I will look for the vitals, sir, whether any
Mhm.
tachycardia, tachypnea is there,
Okay,
whether he is maintaining saturation with oxygen or without oxygen.
good.
He is requiring any oxygen for the, and whether he is febrile.
Mhm.
And on examination, I will look for whether
No, you won't stop.
abdomen.
Yeah, okay, go on. Yeah.
Yes, sir.
There are
Abdomen,
other general things that you need to look for, man, from list that we gave you.
pallor, yes,
Pallor, yes.
pallor,
Yeah. Pulse rate,
pulse, yes, sir. Pulse
regularity,
rate and respiratory.
and if there is regular or not regular, is it an atrial fibrillation? Are there ventricular ectopics that give you an irregular rhythm? What is the state of the JVP before you
Yes.
go to the abdomen? You understand?
Yes, sir.
Yeah. So we just said there could be chest-related problems, lung-related problems,
Done.
heart-related
Yes,
problems.
heart-related problems.
Okay.
Yes.
And you check the blood pressure?
Yes, sir.
Yes. What else would you do? Go on. Now you come to the abdomen.
Yes, sir. With the
Yeah.
abdomen, I will look for the operated side, sir.
Okay.
And
what will it tell you in
whether
a
any
lap collie?
wound site, any discharge is there or not.
Okay. Very, very unlikely, isn't it?
Yes.
Yeah.
Yes, sir. And any tenderness, abdominal distension or any tenderness.
Distension. Is tenderness a reliable sign
It is.
for?
So, it may be surgery related also, tenderness.
Yeah.
So not always, sir.
Yeah, tenderness is a very unreliable sign in the first post-op day abdomen. Okay. Look for distension. Okay.
Yes.
What else? You would listen to the heart.
Yes, sir.
You would listen to the chest for
The
air
heart.
entry.
Yes, sir.
Listen to the chest for air entry. Okay. And you
Yes.
listen to the tummy. Look for bowel sounds.
Yes, sir.
Okay. Now, these things must come to you even in your sleep.
Yes.
Because as a third year, you would be doing all this if you have a problem with the patient. I'm sure you would have seen some post-lap collie patients. All right.
Yes.
So
Yes,
you should really be, particularly in your own life, in your practice, for example, and particularly in exams, these things must come, as I said, as if you're reeling these things off one by one. All right.
Yes, sir.
Yeah. So be aware of all this and be prompt in the way you are hesitating when you answer. There should be no hesitation. There should be a clear, free flow in the exam.
Yes, sir.
Okay.
Okay, sir.
All right.
Yes, sir.
Because also remember that in the exam, the teachers may be aggressive. They may be laughing at you. They may try to put you down if you say something. You must learn to ignore all that and get on with your serious thought process and your answering.
Yes.
All right. That's important.
Yes, sir.
Right.
Yes.
So, Pavan, your turn now. The patient is tachycardic, has a respiratory rate of 22. Okay. Needs 2 liters of oxygen to maintain saturation above 95. Okay. Pulse rate is regular, it is not irregular. The abdomen is distended. There is no tenderness or guarding, but some tenderness in the upper abdomen on deep pressure. Okay, sir. Bowel sounds are absent. Okay, sir. Patient does not have pallor. Okay, these are the findings. What would you be thinking of, and what would you do in terms of investigations?
Sir, regarding, I am thinking about paralytic ileus, sir.
Okay.
So to confirm my diagnosis, I will do abdominal erect X-ray, sir.
Okay.
And the same.
See, this is the problem that I always face when I teach you guys. You would have done it so many times. Suddenly you stop. You know, after X-ray, you stopped everything. If somebody has an alias, what else should you be thinking of?
Sir,
The next thing is, why would somebody get an alias?
Sir, any collection, sir? Because of
What
some,
collection?
the biliary collection at the operator.
Yeah, why can't you just, that's a bile leak, right?
Yes, sir.
Yeah, a bile leak.
So I will go for ultrasound abdomen.
Yeah. Would
So
you do
I
that
will
first or do an X-ray first?
Sir, first I will do abdominal X-ray, sir.
X-ray. How would it give you any more information than an ultrasound? In an X-ray, what would it show?
Sir, any bowel loops are dilated.
Okay. Bowel
And,
loops are dilated for, how do you know there is a bile? You are suspecting bile leak, right?
Yes, sir.
So what would show it better, a plain X-ray or an ultrasound?
Ultrasounds.
Ultrasound. Okay. So
Yes, sir.
I don't mind if you say ultrasound first, but you would also start with some blood tests, right?
Yes, sir.
Bile in the abdomen. What are the things that change in blood
Sir,
tests?
do CBC, sir.
CBC?
Regarding total count, whether there is elevated
Good.
counts are there.
Yeah, the hemoglobin will be all right. There is no bleeding in this by
And,
suspected bile leak. White cell count will be high.
Yes, sir.
All right.
And at the same time, LFT, sir.
Yes. What will it show?
Sir, elevated bilirubin levels.
Yes. Why would the bilirubin be elevated? Good.
Due to, sir, bloat, that means any obstruction to the CBD which may cause the.
There is no obstruction. No, there is a bile leak. Where is the obstruction? You're suspecting a collection and a bile leak. We'll come to obstruction later, but the scenario we are discussing is a bile leak.
Okay,
So
sir.
why would the bilirubin be high? Nikita?
So the fluid which got collected into the peritoneum will be absorbed. Sir.
Correct.
So
Okay.
it is the serum.
Bile pigment will be absorbed. Remember that the peritoneal surface is a huge absorptive surface. So that gets absorbed and you expect the patient to be mildly jaundiced. Okay, because there is no obstruction, there is a leak. Okay, you would not expect the alkaline phosphatase to be high. All right, that's another important thing. If you have an obstruction, you would expect the gamma GT and alkaline phosphatase to be high. All right, so LFT, bilirubin is high, alkaline phosphatase is likely to be normal. What else would you do?
And I will do electrolytes, sir.
Okay.
So electrolyte abnormality is there.
Okay, urea, creatinine, electrolytes.
Yes, sir.
Okay, agreed.
And ultrasound abdomen. I will quantify the amount of the bile leak, whether it is.
Very good. I think, yeah, the ultrasound may say there is a 50 ml fluid collection in the subhepatic space.
Yes, sir.
Then you will then have to determine whether it is important, significant or not.
Yes, sir.
Okay.
So whether we can able to drain it through pictile catheterization,
Yeah.
and we can able to drain the bile.
Yeah. If they say there is a 50 cc collection, would you drain it?
No, sir.
Unlikely. Okay.
Yes,
And you want it to be 200, 300 ml or something. It can be sitting there in the subhepatic pouch or the subdiaphragmatic area on the right side. Then you would first aspirate it,
yes, sir.
see what its nature is, and then perhaps put a pigtail.
Yes, sir.
Okay, if it is bile.
Yes, sir.
Suppose that is the first thing, and we'll come back to what you do further later.
Okay.
Suppose we'll take another scenario. Patient is breathless. Okay,
Yes, sir.
and ultrasound says, sorry, before I go to that, I would like to tell you that a plain X-ray will give you very limited information as to whether there is a dilatation of the small bowel and large bowel or not. It won't tell you whether it is an ileus or an active obstruction. It certainly won't tell you unless there is a huge collection where you may see some haziness. unless it's a huge collection, it won't tell you whether there's a collection or not.
Okay, sir.
Okay. Incidentally, when you do the post-op X-ray, how do you differentiate between a dynamic obstruction and an adynamic ileus?
Sir, in case of adynamic ileus, dilated bowels, and we can see the gas levels at the rectum and in the rectum region also, sir.
Okay. So you will have both large and small bowel being enlarged
Enlarged, yes.
or distended. Whereas in an obstruction, which can happen, okay,
Yes, sir.
if it's particularly small bowel obstruction, the large bowel will be empty.
Yes, sir.
And if it's a large bowel obstruction, very unlikely that you get it on day one. But anyway, theoretically, if it's a large bowel obstruction, you would find the rectum to be empty generally. You're right in that. Okay. So that apart, you will find that the patient has a hemoglobin of 9, whereas the pre-op hemoglobin was 12.2. Okay, on day one, patient breathless. Ultrasound says that there is a collection of about 150 ml in the subhepatic space.
Okay, sir.
Okay, white cell count is raised at 14,000.
Okay,
What are your thoughts now? What would you do next?
sir. I will drain the collection, sir. Through
Would you be able to drain it? This is the way you guys, fall into a trap if somebody is trying to trap you. Okay, do you expect that collection to be fluid? Hemoglobin is down.
So some
It's blood, right?
Yes,
Yeah,
sir. Clots.
Yeah, it's clot.
Yes, sir.
Okay, so it's very unlikely to drain it. So anyway, whenever there is some collection, you always aspirate it first
Okay, sir.
and see what the nature is. Is it bile? Is it blood? Even if there's a clot, there'll always be some blood around it. So when you aspirate it, at least you will not aspirate bile. Then you know that it is just blood, it's blood. Okay.
Okay, sir.
And so when I say the hemoglobin was 9, and what would you do next? When I ask that, I would expect you to look for what in the patient, general condition.
Sir, any general condition, whether
Hemodynamic stability.
stable or not? Yes, sir.
Okay.
Yes,
So
sir.
if the patient is stable, she might have bled 200, 300 ml, and then she would have stopped bleeding. That's why you have a clot sitting there. So would you intervene other than putting a needle in to make sure that it is not bile? Would you do anything else?
No, sir.
Ultrasound guided, of course. No. We just wait, cover her with an antibiotic and wait and watch. If the patient is tachycardic with a pulse rate of 110, you give her a fluid challenge. The pressure improves. Pulse at 110, BP of 80 systolic. Give a fluid challenge, it comes to 100 systolic, and half an hour, 1 hour later after the challenge, the BP systolic comes down again to 80 or 90. Okay, and you elicit postural hypotension. If you do these things, it means there's an ongoing bleeding. That's when you may have to intervene. And what would the intervention be?
Sir, ongoing bleeding, sir.
Yeah,
We'll laparotomy, sir.
laparotomy. I'm talking about a post-laparoscopic cholecystectomy scenario. Why would you need a laparotomy?
Sir, first diagnostic laparoscopy, whether we can
put a laparoscope in again.
and we
Arrange
can-
blood, put a laparoscope in again,
Sir,
suction the whole thing out, and then see if you can
able
locate
to control
bleeder.
it. Yes.
If you locate the bleeder, then whether you're able to control it or not. Okay, if that's possible, that's fine. Otherwise, do a laparotomy. Can I now bring Ramakrishna in? Ramakrishna, nice of you to attend. Please, if you have anything else to add for these two scenarios, sir, bleeding and bile leak.
Bile leak, that's all, sir. Actually, I joined little late, so I
All
missed
right.
that early
Okay.
part.
All right.
And when they were talking about breathlessness
Yeah.
and unwell,
Yeah.
so should you not consider this thromboembolism?
Yeah, we discussed that and we said on day one, thromboembolism is very unusual. unless the patient was bedridden for whatever reason for the 5 to 7 or 10 days pre-op. The patient was hospitalized for something else, was bedridden or whatever. Otherwise, getting a thromboembolism on day 1 is a little unusual.
Sir, Niranjan here, is
Yeah.
there a possibility of carbon dioxide embolism?
Yes,
Can be there
but that
present
will
on
not be day 1.
zero, day zero or day
It will be on the table.
on the table. That's what day
Yeah,
zero.
yeah,
That's
yeah.
what I wanted to know.
Yeah, it won't be the next day. It will be on the table.
Day zero.
Yeah. Okay, so we looked at the bile leak, looked at the bleeding, but then I told you, you find that the hemoglobin is normal. White cell count is 13,000. X-ray abdomen is normal, except for some little distension in the bowel. Ultrasound is normal, no collection. Patient is breathless. Okay. Pulse is tachycardic, but regular. There is no arrhythmia. What would you look for? Indraja.
Sir, I will whether any like hearts or like any
Yeah, you're looking
fibrillation,
at
anything
heart
is
and
there.
lungs, right?
Yes, sir.
So what
Yes,
tests
sir.
would you do? It's very simple. No trick questions in my questioning. Go on.
Sir, chest X-ray, sir.
Yes, good. So what are you looking for in chest X-ray?
Sir, whether any pneumonia, anything is there or not.
Okay.
Whether in any atelectic changes are there
How do
or
you
not.
differentiate between the two? Anybody else? It's a distribution. Sorry, go on. Somebody was go on.
Sir, opacifications will be there, sir, and
Yeah.
opacification in case of
Opacification in
pneumonia.
a pneumonia is
Pneumonia.
you will have it in atelectasis also,
Yes.
but it will be patchy and non-segmental, as it were. Whereas in a pneumonia, it will be restricted to 1 or 2 lobes, okay, of the lung, okay, that the patch distribution. And if it is an embolism with the pulmonary embolism with pulmonary necrosis, what would be the shape of that on the X-ray?
Wedge shape.
Wedge shape. All right, it's a wedge shaped thing with its base on the periphery. That would be the distribution. Okay. So what else? Chest X-ray. What else do you look for that can give breathlessness? Why? No, these are all very common. I think you guys must come out with an answer. As you said, in your sleep. There can be fluid in the pleural cavity, right?
Like pleural effusion.
What is an effusion? When would they get an effusion?
Sir, if any fluid overload.
Yes, very good. Fluid overload.
The overload.
Right heart failure.
Failure. Yes.
All right. And tell me one surgical condition that can give them effusion, which we actually should have mentioned but didn't mention in the initial part of the discussion. What do you think would be one of the complications of laparoscopic cholecystectomy that can give you pleural effusion? Sanya, can you think of something? I gave you a hint that I should have discussed it when we talked about, bile leak and bleeding and things like that, surgery related.
I'm not sure, sir.
Pancreatitis. All right. First
Yes,
post-op day, somebody is breathless. We should have thought of pancreatitis. You should get an amylase and a lipase. Why would they get a pancreatitis? Sanya, tell me.
Because of
Any obstruction that could lead to pancreatitis, sir?
What
Or a slippage of stone during cholecystectomy?
Yes. All right. So if there's a small stone in the cystic duct, when you're in the process of dissecting the cystic duct, you might actually push the stone down the bile duct. And as it passes through, it may give pancreatitis, and that can give you an effusion. So you
Yes.
understand a very simple thing like somebody being breathless can have so many ramifications. All right. So once you make sure that it is not in the lung, then you have to think of the heart. For the heart, of course, you must get an ECG done. And if the ECG shows any changes, get a tropi done. Of course, you will refer to a physician or a cardiologist, but as a surgeon, you can't just refer and keep quiet. You must have some basic things. Look at the ECG, get a tropi done, and get an echocardiogram done. Make sure that there is no, what are the things that you would expect in an echo in these patients if there is a cardiac issue?
Low ejection.
Sorry, low ejection fraction and wall motion abnormalities.
Yes, sir.
Okay, those are the two things that you generally expect when you find a cardiac problem. Okay. Now, what you do with each of these things afterwards is a topic by itself. And I'm already on for 25 minutes with my first slide. So I don't think I'll go through my 10 slides in 1 hour. But what you do, if there is bleeding, briefly we said if the patient is stable, you can wait and watch. Patient is unstable, re-laparoscope and see what the situation is. And we leave it at that for now. And we'll go to the next scenario. Before I do that, Ramakrishna, any other comments, please?
No, sir. I think everything is discussed.
Yeah, Niranjan,
Nothing, sir.
Abdul,
Nothing to add.
nothing to add. Okay. So again, post-lap choline. These things are actually common when you have done a few of these, and you will find face all this as a surgeon. Day 7, patient has come for suture removal. The epigastric wound shows a discharge. Complaints of discharge from the epigastric wound. He says it's a bit bloody, a bit pussy, and you have signs of inflammation. Essentially, the other port sites are normal, but the epigastric port site shows swelling, redness, and tenderness. Okay. Let's involve Vinod. Go on, Vinod. What would you do next? Are you there? I don't see him. Maybe he's. I thought I'd seen him earlier. Okay. Who is Akhil, please? Can you identify yourself?
Good evening, sir. I'm postgraduate from KMC Manipal, sir.
Oh, very nice. So Akhil, why don't you go? Vinod is here. But anyway, you take it up. Take it up, Akhil. What would you do next?
So we will remove the suture and express out the collections.
All right. Next.
We'll take a wound culture sensitivity, sir.
Excellent. And then?
We'll leave the wound open, sir.
Yes.
And we'll give antibiotics.
What would you give? Always in clinic, in your clinic, as I said, I hesitate to say you must say this in the exam, you must say that in the exam, because I believe that the exam must reflect what you do in your clinic, what you do in your life as a surgeon. So what antibiotic would you use? You have a huge array of antibiotics at your disposal. What would you use, and why would you use the one that you have chosen?
Amoxicillin.
Means, okay, amoxicillin clavulanic acid. Good. Why would you use that?
If it is superficial SSI, it would be helpful, sir.
Right? Because you need to have something which covers both gram-positive and gram-negative.
Yes.
Gram-positive comes from skin and its commensals and its pathogens. Gram-negative mostly comes from infected bile. All right? You would have taken the gallbladder from that epigastric wound and you would have some contamination from it. So yes, I would agree with you that your first choice would be like a broad spectrum like amoxicillin clavulanic acid. If the patient is allergic to penicillin, what would you use? With a similar spectrum. Why so silent, Akhil? Would you use a second generation or a third generation cephalosporin?
Third generation cephalosporin.
Why? I put it to you, probably better to use a second generation. Because you need a gram-positive cover also. The higher you go in the generation of cephalosporins, the less activities on gram-positives, more on gram-negatives. Okay? So you
Okay.
can use cefuroxime, for example. That will be a perfectly acceptable alternative. Okay?
Yes.
And okay, you do this, you keep dressing the wound, and the discharge persists for 3 weeks. Patient shows no sign of getting better. The wound swab grows E. coli, okay, sensitive to a given antibiotic. You give that antibiotic for 10 days, irrigate the wound nicely, and the patient is still not better. The discharge continues. So what are the things that go through your mind now?
We'll get an ultrasound abdomen to look for the deep SSI, sir.
All right,
the-
very good, very good. Okay,
If any collection, we can drain that
very good.
pigtail using pigtail catheter.
I agree that you should do an ultrasound at this stage and take it that there is nothing, no collection deep. Okay, 3 weeks, 4 weeks, discharge continues. What are the possibilities? These are real life scenarios. I've faced these and many surgeons face this. Vinod, you want to come in? Are you there, Vinod? All right, it doesn't seem to be there. Is he on call or something?
No, sir.
No.
I'll speak to him, sir.
It's okay, yeah, it's okay. Praveen, you've been very silent today. I haven't heard your voice. Go on. We are now talking about
Yes, sir.
chronic infection, epigastric wound, 3 to 4 weeks, still discharging. You have done everything, proper dressings, proper antibiotics, culture, gross E. coli, but you've given the appropriate antibiotic for 10 days. Patient not better. What happens? No deep collection on ultrasound.
Sir, should check for other source of infection, sir.
Like what?
Like from the if there is any abdominal drain placed.
No, don't. There is no drain, man. This is a regular post-lab
Okay,
call.
yes, sir.
Must be a little tough for a first-year student. You want to have a go, Nikita?
Sir, any foreign body in the wound, sir?
Excellent, excellent. What would be that foreign body?
Sir, any remnant piece of the gallbladder which we have extracted?
More common than a remnant piece? The stone.
Stones.
All right, very
Yes, sir.
good. Stone sitting there is a very common possibility. As you pull the gallbladder out, a little bit of a stone might have got stuck there. Okay, what else? What other foreign bodies possible? Some people have a habit of closing a 10 mm wound. I don't, many of us don't, but some of them do. So it could be a stone, a suture material deep in the wound. It could be a stone, remnant, gallbladder piece, very unusual. Yeah. What else can it be other than a foreign body? What chronic infections do you get in a wound, in any wound, anywhere in the body? Atypical mycobacteria, very common, occurs because of unclean instruments. Okay, If you
Yes,
do
sir.
not have proper sterilization of your cannulae, for example, that you use, you can get atypical mycobacterial infection. All right. So how do you diagnose this? After the initial cleaning and all that we mentioned, if you have persistent wound, you have to do something. And what is that something?
Is it wound debridement, sir?
Yes, in a way, you're right. So under general anesthesia, you cannot walk around and do a proper wound exploration or debridement under local anesthesia. So give a GA, re-explore the wound, extend it if required, go to the depths right down to the peritoneum. Okay, and if there are any remnants of stone, you can clear it. And if you have no remnants of stone, there is something else you must do before coming out. What is that? Pavan,
Sir, suture material, what means?
suture material is not there, stone is not there. So I'm now trying to establish the diagnosis of possible atypical mycobacterial infection. So what should I do as a surgeon?
So we have to send the tissue, sir.
Yes. Why do you take so long to answer? You send it for what?
Histopathological,
Histopathology,
pathological
yes.
and
Gene expert.
microbiology.
gene expert, right? Send it, okay, send it one bit of the sinus wall. It's a sinus, right? The wound sinus. So excise the sinus and send one bit in formalin for pathology and one bit either by itself or in saline for possible gene expert. Okay, and hopefully you get it. Culture is extremely rare. It takes a long time to get the culture back. But if you find granulomata on your histology, gene expert may characterize an atypical mycobacterium. It may not be, but if you find granulomas in your wall, you can take it as atypical mycobacterium and then start treating it. What is the medication that you use for this? I can give you the answer, but I want you to read up about it because I'll be spoon feeding you otherwise. Okay, what's the treatment for atypical mycobacterial infection? I can give you a hint to say that it is not the classical.
Clarithromycin.
Right, good. What else?
Quinolone.
And amoxicillin hydrochloride.
Yes, that's fine. You got it. Just mention clarithromycin, macrolides, and quinolones, and you're okay. All right, that's what you have to use for a good period of time, and you've done a debridement. The debridement is completely taking out all the infected granulation tissue. It may leave you with a big wound there, but then leave it open and then secondarily suture it maybe a week or 2 weeks after you've done the initial debridement, as I call it. Okay, debridement is supposed to be pronounced debridement. All right. Okay, Ramakrishna, anything to add, please?
Sir, how long you give this antibiotics?
3 to 4 weeks.
4 weeks.
Yeah, 4 weeks.
Sir, if it is only a skin infection,
Yeah.
by just leaving the sutures open, is that is enough?
No.
Or you have to give an antibiotic?
Yeah, these bacteria won't go away even if you do a debridement. Okay, you have to treat them. And it will be skin only. It won't be a deep infection. It will be only in the skin and subcutaneous tissue.
Okay, sir.
Niranjan, anything to add?
No, sir. Everything covered, sir.
All right. Okay.
Sir,
Yeah.
what was the reason for initial breathlessness then?
So this is inflammation of the diaphragm. This is whether it is a bleeding, if it is surgical cause, for example, there are several reasons for breathlessness. One of them, irritation of the diaphragm either by blood or bile, and associated ileus that comes with either blood or bile that gives you splinting of the diaphragm. And if there is bleeding and a bit of sepsis that goes with bile leak, that will also give you breathlessness. And if it is bleeding, it is the anemia that goes with the bleeding that can give them tachycardia and breathlessness.
This patient scanning was normal, you said, or there was?
I was giving all scenarios. You probably didn't hear the first part. So I started with No, I told them that breathlessness can be because of surgical causes, surgical complications, or non-surgical or medical issues in the post-op phase. And so breathlessness can occur for many reasons. And so
Yeah.
this particular, I just gave a hypothetical patient. So it wasn't.
Okay. Oh, I thought it is a real patient. I thought.
Yeah,
Okay.
I mean, we have seen many patients, real patients with the same scenarios, but you know, some with bleeding, some with bile leak, some with heart failure and things like that. I put them all into one in this. Yeah. Okay.
Okay.
So
Okay.
yeah. Okay. Now I told you I'm switching gears a little bit. That just to make it a little more interesting. It's not a post-op case, but during a laparoscopic cholecystectomy. Okay, you see a sudden bleeding from the callous triangle, quite brisk, and you are now left with this pumping blood. You know, Praveen, it was Praveen, right, who had the
Yes, sir.
dubious distinction of witnessing one 2 days ago or yesterday, in fact. Actually. Yeah. So,
Yes, yes.
what are your Pawan? Question to you. When that happens, what do you do?
Sir,
You are a very experienced laparoscopic surgeon. Let's start from there and then we'll come down to novices. First, you are a very experienced laparoscopic surgeon. So what would you do?
sir, first I will put one gauze and try to apply the pressures over the bleeder.
Okay. Do you need to put a gauze?
And I'll apply the pressure, sir.
You need to put a gauze is my question. Can you apply pressure with something else?
Pressure.
You can apply pressure with the gallbladder that you have mobilized
Yes, sir.
to whatever extent. You
Yes,
can
sir.
take the momentum and press on it.
Okay,
So it need not necessarily be gauze. Yeah.
Gauze.
Okay. Okay. How
Yes, sir.
long do you put the pressure for?
Sir, for 3 to 5 minutes, sir.
Yes. And don't keep on taking it out and watching every 1 minute or 2 minutes. Put a pressure and keep it there. Okay. And just watch that ongoing bleeding is not there for a good 3 to 5 minutes. And then slowly take out your pressure and see if you can see the blood vessel. Okay. So if you see the blood vessel,
Yes.
what would you do?
Sir, then I will try to apply that hemoclips, sir, or clips. Or I
Any
will
clip.
cut.
You will first dissect the structure, the blood vessel away from what structures. You need clarity in this before you put a clip. You don't blindly apply clips, right? So what are the structures that you're concerned about when
Sir,
you're dissecting this bleeding vessel?
Sir, CBD, sir.
CBD, very good.
And
First thing,
hepatic artery, sir.
yeah, right hepatic is the most common.
Right hepatic.
for
Yes,
the
sir. Right
body.
hepatic artery.
Right. And if you go at a more posterior or deeper level, you can even think of the portal vein. But
Portal
that's distinctly unusual. So if you first think of the CBD and the right hepatic artery, and then if you can dissect it out away from that,
Okay.
okay, then you can dissect it out and apply a clip. That's one. Suppose you cannot dissect it, your pressure does not stop the bleeding, and you do not know what is happening. Then what do you do?
Sir, conversion to open, sir.
Good. Open the patient. All right. Even if you're very experienced, you open the patient so that you have a good look. Now you find that the bleeding has stopped.
Okay, sir.
With your pressure, but you don't know where the bleeding is coming from. I mean, you don't know which vessel gave way. Then what do you do? These are all the possibilities.
Sir, I will try to identify whether which vessel is bleeded or not.
Okay.
That means bleed
Very
or not.
good. Very good. That's the answer I wanted, because what are the common vessels that would possibly be bleeding?
Sir, here I will first think about cystic artery, then hepatic
Yes.
artery.
Right hepatic artery, and if it's
And,
neither of them,
then unusually portal vein, what is it?
portal vein is very unusual, but even more common than that is the cystic duct branch of the cystic artery.
Cystic branch.
Cystic artery gives off a branch to the cystic duct that itself can bleed. So how do you decide which one is what in all these three scenarios? The key is to actually dissect the cystic duct.
Yes, sir.
Make sure that the duct is well off these vessels. And if you're lucky, if the pressure has stopped the bleeding, then you can see the anatomy. You can see the cystic duct, you can see the bile duct, you can see where these vessels are, which will be separate from the cystic duct, and then you can either apply clips or tie those vessels.
Okay.
Depending on where. But the important thing is that you must get around this vessel that has bled. Okay, do not blindly keep clipping because you do not know what you're clipping. In addition to the vessel, you may be clipping the hepatic duct, right hepatic duct, you can be clipping the right hepatic artery. And so blind clipping is to be avoided. Define what you're doing and get around the vessel and either clip it or tie it. And even if you're very experienced, there's one other thing that you should not hesitate to do. And what is that?
Conversion to opens.
Conversion is done. And in addition to that,
Keeping a drain.
call for help.
Call for. Okay, sir.
As a surgeon, that's something you should be very, very free to do, particularly when you're junior, and more importantly when you're senior, because somehow the more senior you get, the more hesitant you are to call for help, but you should not be hesitating. Call for help. Another mind working on it will be very useful. Okay, and there are two general things that you have to do where you need to take the help of the anesthetist. What are those two things when somebody is bleeding inside?
So regarding the blood pressure, sir, and
Yes.
hemodynamic status of the patients.
Yeah, the anesthetist must be asked to tell you about the hemodynamic status, tachycardia, amount of fluid that is required to keep the pressure up, and what else? Cross-match blood.
Yes, sir.
As a surgeon, it is a responsibility, to assess whether a particular bleeder will take time and bleed a lot. But normally you do not cross-match blood for these patients. So you must ask the anesthetist to take blood and cross-match quickly. Okay, that is about the dissection. Now, one other important thing that you must know when there is bleeding is to understand the sites from which you can bleed and what are the things that you do to stop the bleeding. We talked about the cystic artery, the right hepatic artery, either tying or clipping after defining the blood vessel and making sure that it is separate from the bile duct. Okay, those two are clear requirements. Now, can something else bleed further laterally? It's neither the cystic artery nor the right hepatic artery. More laterally, away from the midline, away from the bile duct area, what can bleed? Indraja, you must have seen it many times during your lab colleagues. You would have seen hundreds of lab colleagues, third years. Yeah. So I'll ask you a more direct question. What usually bleeds from the gallbladder bed?
Sir, I'm not.
Not sure. Nikita, you want to take a guess?
Is it liver itself, sir? Liver sinusoids or?
Liver sinus, you're right. Not liver sinusoids. Venous sinuses. Venous sinuses. Big veins that drain from the gallbladder into the hepatic bed, into the gallbladder bed of the liver. Venous sinuses. So the difference between that bleeding and the bleeding from that we discussed earlier is the pressure. This is a venous bleed. It's more a ooze rather than a big spurt. Okay, so what are the tricks to stop the bleeding from a venous sinus? Go on.
Sir, we can
Indraja.
put a Surgical or
Yeah, one is pressure. Next is some kind of a hemostatic agent, like, so you can put Surgicel and put pressure and weight. All right. If these things don't work, what do you do?
So we can use cotton, sir, to
Pottery
cauterize
is
the liver bed.
sometimes it make it worse. Actually, sometimes it makes it worse because it opens up a bit more. Okay. You can try pottery. I'm not saying you should never try it. Bipolar is better than unipolar. But sometimes it opens up and sort of disappears into the hepatic bed.
So
you
we
can't
can
even-
use momentum as
That is, pressure is over, no momentum, gauze, gallbladder itself, all these are pressure. That's gone. You put some Surgicel, that's not working. You cauterized it and the bleeding got worse. Then what do you do? Suture it, okay?
yes,
Suture
sir.
ligate it. And then you take it from the depth, and that is what that will stop the bleeding. Okay.
Yes.
That's the, yeah. So that is the course of action or the algorithm as far as bleeding is concerned. Niranjan, anything to add?
Nothing, sir.
All right.
Almost everything is covered, sir.
Okay. Now, Krishna sir, is he there?
Yes, sir. Yes, sir.
Yeah.
Yeah.
Anything else to add, sir?
Usually I use bipolar cartridge. Sometimes with the spatula also we can spray
Yeah.
the
Spray mode is
not
also.
spatula, just superficially keep and cauterize. Most
Yeah.
of the time it stops.
It
I
stops,
have
yeah.
never required
to
a
suture.
surgery. Yes.
Okay. Yeah, I must say I've had to suture once or twice, but I agree, not very common. All right. It's nearly an hour now. I have actually 4 or 5 more scenarios, but I think we should discuss it later. We will stop at this point.
Another 10 minutes.
Sorry?
Another 10 minutes.
Another
you can
10
go.
minutes, can we do it? Yeah, okay. Okay. Now this is another interesting scenario. Okay. You have done what to you looks like a completely uneventful, straightforward gallbladder. Okay. And then as you're about to you extracted the gallbladder and you're just having a final look, and you see a small, thin, clear bile pool, okay, in the area of the cystic duct that you have clamped. Okay. What goes through your mind? Pavan?
Sir, injury to the CBD, sir.
Okay. Why do you say it is not some bile from the gallbladder, something that poured out of the gallbladder when you
First,
extracted it?
Sir, first we will give thorough wash, sir.
Yes.
And we will see whether the bile is still coming or not. Then we will
Okay.
see where it's coming from.
All right. My question is, even without doing all this, just
Yes,
by the description that I have, okay, you can say that it is not from the gallbladder. Why do I do that?
Sir, actually in gallbladder, so the bile is thick, sir.
Good. And darker.
Dark, sir.
Okay. Gallbladder bile is, and the thing that comes from the biliary duct, biliary tree,
Yes.
okay, not necessarily bile duct, but I would say biliary tree, other than the gallbladder, okay, would be thin and clear yellow bile. All right. You mentioned about damage to CBD. What are the other things that could have happened? Not necessarily damage to CBD.
Common hepatic ducts
Okay.
or while clipping that right branch of the hepatic duct near the confluence, confluence.
Right. You can damage the right hepatic duct, common hepatic duct, common bile duct.
Yes, sir.
What else? You must have all this in mind.
Yes.
The cystic duct may not be clipped completely. You may not have gone across it completely.
Completely.
Okay. And one other thing that you have to mention. It's very important.
Yes, sir, I think it.
Accessory duct. You can have accessory ducts that go directly from the gallbladder into the liver, apart from this main tree, the biliary tree. Okay, so as you've done everything right, you identified the cystic duct correctly, not damaged the CBD or the right hepatic or the common hepatic duct. Put your clip properly, but this duct will be going from the gallbladder directly into the liver through the gallbladder bed, and that can also leak. Okay.
Yes.
Now, when you see this pool, the first thing to recognize is that you have some kind of a damage with the biliary tree, so you don't close and come out. As you said, give a thorough washout and see where the bile is coming from. And you try a lot, you don't know where it's coming from. What do you do next?
Sir, ERCP, sir.
What are ERCP? You're on the table, man. There's bleeding. Are they going to do the ERCP on the table? Yeah, I'm not saying it should never be done, but is it normally done average in an average hospital? No, not done. So as I said about bleeding, what's the first thing that you do? Particularly if you're a junior surgeon, and even if you're a senior surgeon.
Sir, call for help.
Please always mention it in the exams, and more than exams, my interest is you are a surgeon operating on a patient. Okay, so that's all what you should do for safety to the patient. That is my primary concern. Ask for help.
Yes.
Some other surgeon may be able to do something that you have not seen. And I won't go into the details of what are all things that can be done, but some of the easy things that can be done is to reapply a clip on a good cystic duct stump. If the cystic duct is leaking, if you can see an accessory duct, you might either be able to clip it or put a suture to it. And if the CBD is damaged, it depends on the size of the CBD. You may be able to suture close, not ligate, suture close the hole in the CBD. Suppose you do not know where the leakage is from. What are the two things that you have to do?
So conversion to open, sir, first.
Conversion to open is possible, but you feel that conversion may not actually tell you where the actual leak is, even if you are converted. Maybe you do not have the confidence to deal with a CBD damage as an open surgeon. So what are the two things that you do? Record all this very truthfully and nicely in your operation notes. Put a drain. Put a drain into the subhepatic space and come out. Give antibiotics, because even with the drain, you expect some degree of bile leak and infection. Okay, some cephalosporin, third generation, which would cover biliary organisms, would be a correct antibiotic. Give that, record all this, and then ask for an ARCP. One other option that you can do is to do an on-table cholangiogram. Even before putting a drain and coming out, you may be able to you can either put a small needle into the CBD, if you can see it clearly, put a small needle into it and inject it, or you can undo the clip if you can on the cystic duct, put a catheter through the cystic duct and take an on-table cholangiogram. All this should be done by experienced people. It's not for beginners, okay? But these are your options. You can put it in and you can see where the leakage is. And as you said, sometimes you may not be able to see where it is, in which case it's perfectly logical to record whatever you have done, whatever you saw very truthfully and completely, put a drain and get out. Okay, and then you can do an ERCP to see at a later date, 24, 48 hours, 72 hours later, to see exactly what the biliary tree is and where the damage is. Okay, so these are the steps that you do practically when you see a thin, clear bit of bile suggestive of bile from the bile duct or the hepatic ducts. Okay, Niranjan, anything to add?
Sir, only thing is that sometimes there can be in difficult gallbladders, it can be because of the gallbladder, you have resected it from the gallbladder bed and liver injury there, liver damage there can produce bile leak. And most of them, like if you can't find the source and if you have come out, kept a drain and come out, probably they will stop in few days.
Yes,
That's the only thing which I
True.
want to add.
true. Yeah. Ram Krishna, sir.
Yes, sir, I agree with Dr. Niranjan. That type of scenario I had once,
Yes.
and post-operatively stopped in about 3 to 4 days.
Yeah.
It happens.
Okay, I think it's 10 o'clock. There are a few more scenarios as we go along, but when you get another chance, maybe for another ward round, we'll do it. Okay. Any questions or comments from the students and the registrars? Abdul,
No, sir, nothing. to add.
Sanya?
It was a nice class.
No, sir, nothing.
okay, questions? Okay, if there is nothing else, I thank you for your participation. Okay, and I'll close the meeting. Thank you very much and good night. Oh, sorry, I'm sorry.
Thank you.
I have not seen the chat box because, I was on full screen. Okay. Okay, you're talking about the case scenarios, so I think we have discussed that. What about metronidazole and tinidazole? Yeah, I think it's important to know that a non-obstructed biliary tree, okay, which is what we would be normally seeing in gallbladder, is very unlikely to have gram, anaerobic organisms. It is only the obstructed biliary tree which can have anaerobic organ. Otherwise, it's usually gram-negative organisms. Okay. Yeah, calculus deep there. Yeah, that's one. All right. Fine. So there are other things that have been talked about, have been covered in our discussion. Okay. Thank you very much. Good night, and hope we'll have another opportunity to discuss other scenarios, post-op scenarios. I'll end the meeting now. Thank you and goodbye.
Thank you,
Okay.
sir.
Thank you.